Sir, we are on live. We'll wait for 2 minutes, sir.
சரிங்க, நீங்க சொல்லுங்க எப்போ ஸ்டார்ட் பண்ணுங்க.
Okay, sir.
எப்படி 1 ஹவருங்களா இல்ல இது 45 மினிட்ஸா?
Sir, 1 hour we can do, sir. 6:30 to 7:30 தான் session.
Okay.
We can do it for 1 hour. Shall we start, sir?
Yeah.
Okay, good evening, viewers. Happy to meet you all again in this wonderful evening. I welcome you all for the session on behalf of Indian Medical College. Today we have Dr. Vinoth Doraiswamy sir with us. Sir is from PSG Medical College, Coimbatore. Sir has done MD Pediatrics, MRC, CPCH from UK, and FNB Pediatric Cardiology. It's a great privilege for us to have a sir with us. Sir is having a lot of teaching experience and research experience. Sir is going to deliver a talk about A to Z of ECG today. If you are having any doubts in the middle, you can always use the chat section, live chat section, which is enabled below. So sir will be answering all your doubts at the end of the session. Shall we get into the presentation, sir?
Yeah, we'll start.
Yes, sir, please.
So good evening, I'm Dr. Vinoth Doraiswamy. Thank you for the introduction, Dr. Karthik. So I'll be speaking on the basics of ECG reading. So ECG is like a very long topic, so you'll not be able to cover in one session. Might require maybe a second or a third session. I'd like to do this presentation slowly, so it will enable you to grasp the concepts of ECG, which is very important. So now we'll start with what is an ECG. It's basically a visual representation of the electrical activity of the heart over time. And the deflections which you see in the ECG represent summed up vectors. So a vector will have a magnitude and a direction. And these are measured on the surface of the body, corresponding with the electrical activity in the heart. So the factors that affect the ECG is the lead placement. So where you place the leads, any electromechanical interference nearby, movement of the patient. For example, if he's having a seizure or having fever with chills, rigor, and his body habitus. So if a patient is very obese or he has a pericardial effusion, or he's having like a COPD with lots of air in the lungs, then it'll affect the amplitude of the ECG complexes. So all this has to be taken into account while trying to read the ECG. So consider this 8-year-old child who had a subdural empyema who was intubated. Chest X-ray showed cardiomegaly. So I was called an opinion to see if there was any associated myocarditis. So ECG was taken. So when you look at this ECG, it looks very bizarre actually. You can see multiple abnormal waves which are not able to identify what they are, P wave or T wave. We are actually not very sure. So we might think this might be an arrhythmia. But actually, when I went to examine the patient, this patient was ventilated. So he was having like some left focal seizures which were very subtle. So the sister who took the ECG did not notice those seizures. So if you're taking a patient who's having any fever with rigors or seizure, they'll have lots of mechanical disturbances like this. So it's better to terminate those seizure and then after that take the ECG. And the ECG which was taken after that was normal. So now coming to the electrocardiograph. So the electrocardiograph is basically a galvanometer which and each lead will have a positive and a negative electrode. And this galvanometer will detect the electromagnetic potential which is there between the negative and the positive electrode. Okay, so these paired electrodes will detect changes in the electromagnetic potential along the axis of the lead, as I've mentioned. So the electrical field of the heart. So as I said, is the heart is situated at the center of the electrical field it generates. And as you put the electrodes farther and farther away from the heart, the intensity which is picked up, that is the amplitude of the ECG picked up, will decreases. But greater than 15 centimeters, the decrease in intensity is negligible. So when we come to the leads, so we have frontal leads and we have horizontal leads. So frontal leads, we actually have 6. We have standard limb leads, which is lead 1, lead 2, and lead 3. And we have augmented unipolar limb leads, which are AVR, AVL, and AVF. And when coming to the horizontal leads, we have unipolar chest leads. We can see over here, V1 to V6. So I'll talk about each of the leads and where to place them. But in addition to that, now when you take an ECG, it's not exactly 12 leads, minimum 14 leads. So you can have V3R and V4R, or even you can go leads behind V6, like V7, V8, and V9. So coming to the Einthoven's triangle, so the 3 leads, that is lead 1, lead 2, lead 3, which are the standard bipolar limb leads. Lead 1 will be between the left arm and the right arm, with the left arm being positive. Lead 2 will be the right arm and left leg, with the left leg being positive. And lead 3 will be between left arm and left leg, with the left leg being positive. So these 3 leads will form a triangle, which is known as the Einthoven's triangle, and the heart is the center of that Einthoven's triangle. So how do you, these are the bipolar limb leads. So now, what are these augmented unipolar limb leads? So these unipolar limb leads, as we said, are AVR, AVL, and AVF. That is right arm, and left leg. So each lead should have a positive terminal and a negative terminal. So the positive terminal will be connected to the desired limb. For example, if it is an AVR, the positive terminal, or the exploring electrode, as we say, is connected to the right arm. Now, initially what was done is, this is actually an augmented unipolar limb leads. Initially, when they took the ECGs, they did not augment it. What it means is, for the negative electrode, which is also known as the reference electrode, the 3 limbs, that is the left arm, right arm, and left leg, are connected to a negative electrode, which is called the Wilson's central terminal. And then when they did that, they found out that the amplitude got from the AVR was very less. That was because both the exploring electrode and the one of the leads of the negative electrode were connected to the same right limb. So what they did is, they took out the negative electrode from the, that is the right hand, they took it out from the negative electrode, so to increase the potential. For example, here if you see VR, that is before it is augmented, the positive electrode was connected to the right hand, and initially the Wilson central terminal consists of electrodes connected to the left hand, left leg, and right arm. So because the positive and the negative electrode were both connected to the right hand, they cancelled each other and the amplitude was low. So from the negative, that is the reference electrode, they took out the connection to the right arm. So this is why it is called as an augmented unipolar limb lead. So this is the same with the other leads. For example, lead AVL, the positive will be connected to the left hand and the negative will be connected to the right hand and the left leg. Now, when we see an ECG being taken for anybody, we'll be also seeing that is a lead is also being connected to the right leg. Till now, we have not discussed about the right leg, but the lead on the right leg is just there like an electronic reference to reduce the noise. It does not take part in the actual ECG. Then coming to the unipolar limb leads. So the unipolar limb leads, which we said is AVR, AVR, and AF, you have to know where they are oriented. So this is the heart. The AVR is directed towards the internal cavity of the heart, and the AVS is directed towards the inferior surface of the heart, and AVL is directed towards the lateral surface of the heart. So it's important to know where these leads are placed, so you know which part of the heart you're covering. So as I've already said, then coming to the horizontal plane leads, okay, all the unipolar chest leads. So here in this case, the positive terminal is connected to the designated chest lead, and the negative terminal will be connected to the Wilson central terminal. That is the combination of the right hand, and left leg. Okay, so usually standardly we use 6 chest leads or unipolar chest leads. So I'm sure you all know where they are connected, but we'll just revise. So V1 is connected to the right 4th intercostal space at the parasternal region. V2 is the left fourth intercostal space in the parasternal region. V3 will be between V2 and V4. So V4 is in the left fifth intercostal space in the mid-clavicle line. Then you draw a horizontal line from V4, okay, towards the axilla, and V5 will be on that line in the anterior axillary line, V6 in the mid-axillary line. And sometimes when we want to get, like, if patients having like a severe left ventricular hypertrophy, we might not get the complexes at V6, so we might have to go behind. So V7 will be at the posterior axillary line along that same horizontal line. V8 will be at the scapular line, and V9 will be at the parasternal line. So we can even go up to V9. Same thing nowadays, just like V3 and V4, we use leads like V3R and V4R. So R stands for right side. They are the same position as V3 and V4, but on the right side of the chest. So these are useful. Suppose the patient is having a congenital heart disease with a dextrocardia or maybe a right ventricular infarction, to take up the complexes from those leads. So the unipolar chest leads, now which parts do they cover? The V1 and V2 are mainly the anterior surface and the right surface of the heart. V3 and V4 are the anteroseptal portion, and V5 and V6 are on the lateral surface of the left ventricle. So it's important to know the position of the leads when you're looking at the ECG. Now coming to the Einthoven's triangle, the hexaxial reference system. So based on, this is in the frontal plane. So it will include only the leads 1, 2, 3, AVR, AVR and AVM. So it's important to know the axis or the degrees of these leads, so that we can calculate the QRS axis, the P axis or the T axis. So based on the orientation of the Einthoven's triangle, lead 1 will be 0 to 180 degrees, with 0 being positive. Lead 2 will be 60 to 120, being 60 being the positive part. AVF along the 90 degree. Lead 3 120, AVR minus 150 and AVL minus 30. So this is the hexaxial reference system, which is very important when we're calculating the QRS axis. So the basic action of an electrocardiograph is it has to detect the electromagnetic potentials which are going between the negative terminal and the positive terminal. So if the vector, which has both the direction and magnitude, as I have told before, is going towards the positive lead, then you will get a upward deflection above the baseline. If it is going away from the positive lead, you will get a negative deflection, that is below the baseline. And depending on the magnitude of the vector, you will get a very large spike. If it is small magnitude, you will get a small spike. So what happens if the vector is going perpendicular to the lead? So you have a negative and positive. If it is going in this direction, perpendicular, then you will get an isoelectric complex. That is, the positive and the negative will be equal. So that is also very important when we're calculating the QRS axis, which we'll come to later on. So again, the orientation of the ECG leads, if we see everything, 2, 3 and AVF will be the inferior surface of the heart. 1 and AVL will be the lateral surface of the heart. AVR is towards the cavity of the heart. V1, V2 is the right ventricle or the anterior surface of the heart. V3, V4 again anteroseptal and apical, and V5, V6 will be the lateral. So it's important to know the position of these leads while reading the ECG. So coming to the leads, now we're coming to the ECG paper. So you know the ECG paper is like a grid-like. It consists of multiple small squares, okay, and each small square. So basically ECG has an x-axis and a y-axis. So time is along the x-axis and magnitude is along the y-axis. So each small square is 1 millimeter, okay, and 5 small squares will make a large square. Now the standard ECG paper runs at the speed of 25 millimeters per second. Okay, and the voltage will be, that is on the y-axis, will be 10 millimeters equal to 1 millivolt. This is the normal standardization. Okay, so this is the way the ECG is there. So how do we know how much is each small square? Each small square is 1 millimeter, which is equal to 0.04 seconds or 40 milliseconds. So how does it come to that value? So we know that 25 millimeters in 1 second, which is equal to 1000 milliseconds. So one small box is 1 millimeter. So it will be equal to 1000 by 25. So 1 millimeter is 40 milliseconds or 0.04 seconds. So if one small square is 0.04 seconds, then one large square will be 0.04 into 5, which is 0.2 seconds. And 5 large squares will be 1 second, and so on. So the technical constitution of the ECG. So when we're reading the ECG, there are certain numbers that you will see, either the bottom or the top of the ECG. This is the speed, the 25 millimeters per second, and this is the standardization. That is 10 millimeters is equal to how many millivolts, and then you will see a frequency. So how much of the ECG cycles are sampled per second. So it's usually around 150 hertz. So the normal standardization is 10 millimeters equal to 1 millivolt. So you will see like a line over here. You can see on the side here. So this will be 10 millimeter, which means 10 millimeter is equal to 1 millivolt. But sometimes you will see only equal to 5 millimeter, which means 5 millimeter is equal to 1 millivolt. So sometimes if the ECG complexes are very large on the normal standardization and the ECG complex will overlap of the ECG complex of a particular lead will overlap the ECG complexes of the preceding or the succeeding lead, they might go for a half standardization to reduce the size of the complexes so that you can study it properly. Okay, so this is a half standardization where 5 millimeter is equal to 1 millivolt, and then you have a double standardization. If the complexes are too less and you want to increase it, you can go for a double standardization. Okay, and that 20 millimeter is equal to 1 millivolt. So here you see the ECG. Now, when you see the ECG, you will see complexes like, for example, V2 and V3. You have a biventricular hypertrophy, but you might think that the ECG complexes are not too big. But now when you go to the standardization over here, you can see the first half is 10 millimeter and the second half is 5 millimeter. So either the separate standardization will be there for the limb leads and for the chest leads, that is V1 to V6. So either it will be written 10 millimeters equal to 1 millivolt separately for the limb leads and the chest leads, or it will be given in this. So this first half 10 millimeter means the limb leads 10 millimeters equal to 1 millivolt, and then the second half, which is showing 5 millimeter, means 5 millimeters equal to 1 millivolt, which is half standardization. That means the chest leads. So here the chest leads are only half standardized. So if we would take it in full standardization, the complexes will be very large. So this patient is having a biventricular hypertrophy. So all these parts of the ECG we have to take into consideration before reading the ECG. So again, the ECG showing the speed 25 mm per second. So sometimes it will be given separately, limb 10 millimeters per millivolt or chest 10 millimeters per millivolt. Or if it's not there, you will have to see this complex. So the first half will be for the limb leads and the second half will be for the chest leads, like we have seen in the previous example. So usual speed is 25 mm per second with a full standardization of 10 millimeters equal to 1 millivolt. So coming, we'll have to know now what is the normal AV conduction system. What is the structure? If we have to understand how to read the ECG. So we know that the pacemaker of the heart is a sinoatrial node, which is a group of cells located at the superior vena cava and right atrial junction, okay, at the sulcus terminalis. It is a subepicardial structure, and from there the impulse will generate. After the impulse is generated, it will travel in the right atrium towards the AV node through selective internodal pathways, and through the Bachmann's bundle, it will also go from the right atrium towards the left atrium. So by this way, the atrium is depolarized. Okay. Now there is no electrical connection between the atria and ventricle in the normal heart, except this AV node and his bundle. So the only way for the depolarization wave to travel from the atria to the ventricle is through the AV node and the his bundle. So the AV node is present in the lower part of the right atrium near the septal leaflet of the triangle, the tricuspid valve. The AV node and the his bundle will pierce the central fibrous trigone, then it will pierce the membranous septum. After it pierces the membranous septum, it will come to the crest of the muscular septum, okay, where it will divide into two bundles. One is the right bundle and one is the left bundle branch. So the right bundle branch will go on the endocardial surface of the right interventricular septum, and it will form the Purkinje fibers. And the left bundle will divide into actually three fascicles. One is not shown: the left anterior fascicle, the left posterior fascicle, and the left septal fascicle. So and then it will end in the Purkinje fibers. So these Purkinje fibers will anastomose with the endocardial myocytes, okay, of the right ventricle and left ventricle. So this only allows for the coordinated contraction of the right ventricle and left ventricle within a few milliseconds. So this is the normal atrioventricular conduction system. So ECG reading during undergraduation, these were the typical responses that we got, or that we also felt when we were doing undergraduation. So it's very important that we learn the basics concepts and we practice it every day. Then only we can excel. So now coming to the ECG components. So we know the ECG components has a P, Q, R, R dash, ST, U waves, J point, ST segment. So the P wave represents the atrial depolarization, okay, and PR interval, that is from the start of the P wave to the start of the QRS complex, represents atrial depolarization and AV nodal conduction delay. Atrial repolarization is usually a very low amplitude complex and it's buried in the QRS. So that is why we cannot see the atrial repolarization. QRS shows a ventricular depolarization, and QT interval starts from the Q wave up to the end of the T wave. It represents both ventricular depolarization and ventricular repolarization. T wave being the ventricular repolarization. So QRS is ventricular depolarization and T wave is ventricular repolarization. Now J point, that is a junction between the QRS complex and the ST segment, which is very important when you're looking for ST elevation or ST depression. So ST segment is the interval between the ventricular depolarization and ventricular repolarization. And U wave, sometimes you see a U wave, which is a small wave, usually in the same polarity as the T wave. After the T wave, it possibly represents a His Purkinje system repolarization or repolarization of the M mid-myocardial cells, which are present between the epicardium and the endocardium. So that is the U wave. So coming to the systematic ECG interpretation. So first you check the standardization and the speed, which we have done in the previous slides. Consider the patient age. So some things which are normal for the adult may be abnormal for the child. So you know that children have normally a higher heart rate. So all the intervals like PR interval, QT interval and all will be shorter. So maybe the axis will also be different. So we have to consider all that. So always consider the patient's age and physiological status. And we have to know what is the calculated rate of the ECG and see if it's a sinus rhythm or not. And we'll deal with this in the subsequent slides. Then the intervals. I told you the PR interval, QRS interval, and QT interval. Axis, you can calculate the QRS axis, the P axis, and the T axis. Then analyze each and every waveform and see for ST segment abnormality. So we'll go through each of this one by one. So coming to the ECG heart rate. So heart rate has to be appropriate for the age and the physiological status. So how do you calculate the heart rate? So we know that the paper speed is normally 25 mm per second. 1 mm is one small box. We know that. So usually you know that heart rate we calculate in beats per minute. So 25 small box in 1 second will be 25 into 60. So that is 1500 small boxes in 1 minute. So one heartbeat we have to calculate. That is one RR interval between one QRS complex and the next QRS complex. How many small boxes that contains? So suppose it contains 10 small boxes, then the heart rate will be 1500 by 10, which is 150 beats per minute. Suppose that's a small box method. Then you have the large box method. So just like 25 small boxes make 1 second, we know that 5 small boxes make 1 large box. So which means 5 large box makes 1 second. So 1 minute will be 5 into 60, which will be 300 large boxes per minute. Find out how many large boxes the R interval contains. Suppose it's 2 large boxes, then 300 divided by 2, which is 150 beats per minute. So it's the same. So we'll come to an example. So it's a 50-year-old man who came just for a normal master health checkup. So now you want to calculate the heart rate. So as I said here, the small square method, paper speed is 25 mm per second, which is 25 small box per second. Sorry. Okay. So 1 minute will be equal to 25 into 60, that is 1500 small squares, right? So the RR interval, we have to know how many small boxes. So it's actually 20 small boxes over here. So the heart rate will be 1500 by 20, which is 75 beats per minute. You can also use the large square method. So again, 5 large boxes per second, 300 large boxes per minute. R interval is 4 large boxes. So 300 by 4 is equal to 75 beats per minute. So both ways you get 75 beats per minute. So this is a small square and large square method. So initially it might seem difficult, but when you go on practicing every day, you will come to know that if you see an RR interval which is only 5 small squares, it will be 300 beats per minute. 10 small squares, 150. And then 15 small squares, 100. 20 small squares, 75. Automatically come to you. So you don't have to calculate each time 1500 divided by number of small squares. And then you have the large box methods. You can even use the millisecond method to calculate. For example, you can find out you know that in 1 minute, there are 60,000 milliseconds. So find out the number of milliseconds between the RR interval. So you know that one small box is equal to 40 milliseconds. So this RR interval will be 14 the number of small squares, which is 1750. Divide 60,000 by 1750 and you'll get the heart rate. So you can use a millisecond if you want, if you don't want to use the small box and large box method. So it's important, as I said, to know the age of the patient. So an adult normally will have a heart rate between 60 to 100, and generally we say above 100 is tachycardia and below 60 is bradycardia. But a newborn, normally his heart rate can even go from 120 to 160. So tachycardia will be only above 160. So you should know the general heart rate, what should be according to the age of the patient before diagnosing if it's a tachycardia or an arrhythmia. So now I've seen the rate. So we have to calculate the rhythm. So we want to know if it is a sinus rhythm. If it is not a sinus rhythm, is it an ectopic atrial rhythm, which means the rhythm is coming from the atria but not from the sinus node. That is some other point of the atria. Or is it a junctional rhythm? Is it coming from the AV node, or is it coming from the ventricle, which is an idioventricular rhythm? Okay, so we'll go through each one by one. So for saying it is a sinus rhythm, you need 2 things. Okay. Each P wave has to be succeeded by a QRS complex, okay, with a constant PR interval. and the axis of the P wave should be normal. So how do you calculate the axis of the P wave? So we know that this is the sinoatrial node. This is the AV node. So definitely the wave of depolarization has to go in this direction, which means the wave of depolarization of the atrium has to go in this direction, that is towards the lower left quadrant. So for the P wave to be of normal axis, it should be between 0 to 90 degrees, which means it should be positive in 1, 2, and AVF. So if it is positive in 1, 2, and AVF, and if a P wave is succeeded by QRS complex each time with a constant PR interval, then it is a sinus rhythm. Suppose the P wave is not in this left lower quadrant and is in the other quadrants, then it is an ectopic atrial rhythm. Okay, so we'll go to examples of each. Now, what is a junctional rhythm? So if there's no P wave before each QRS complex, it can be either a junctional rhythm or an idioventricular rhythm. In a junctional rhythm, it will have a narrow QRS complex, and a ventricular rhythm, it will be a wide QRS complex. So why we'll see subsequently. So this is a 4-year-old boy coming with a chest pain, which is a non-cardiac chest pain. Okay, so you want to see is this sinus rhythm or not. So what is the first condition? Each P wave should be followed by a QRS complex. Okay, this P waves, these so many P waves you're seeing, and each one is followed by a QRS complex with a constant PR interval. Okay, so that is correct. Now we want to see the P wave axis. So we know that the P wave axis should be in the left lower quadrant. Okay, so which means it should be positive in 1, 2, and AVS. So this is satisfied. 1 it is positive, 2 it is positive, and AVF it is positive. So it is normal P wave axis. So this is a normal sinus rhythm. So a 12-year-old referred for an irregular heart rate. So a general practitioner had seen this child oscillate and felt that the heart rate was irregular. So you can see clearly the heart rate is irregular. So here it is becoming fast, and here it is becoming slow, and again is becoming fast. But this is called as sinus arrhythmia, which is actually a normal phenomenon. Okay, sinus arrhythmia basically means during inspiration the heart rate increases, and during expiration the heart rate will decrease. So it's typically seen in children and young adults. It's due to the increased vagal tone, and it is an indicator of good cardiovascular health. So more vagal tone, athletes have more vagal tone, so they have better cardiovascular health. Loss of a sinus arrhythmia, which was there previously, might mean that the patient has an underlying heart failure or a structural heart disease, and is due to the Bainbridge reflex. So what is the Bainbridge reflex? So during inspiration, we know that the diaphragm gets pulled down, the intrathoracic pressure decreases, so more venous return happens to the IVC and the SVC to the right atrium. There are certain receptors called the Bainbridge stretch receptors present at the SVC RA junction. So those will get stimulated. They will go to the sympathetic centers and increase the sympathetic output. So it will cause tachycardia. So during inspiration, more venous return, more tachycardia. Opposite happens during expiration. So it is a normal reflex called as the Bainbridge reflex. So respiratory sinus arrhythmia is a normal phenomenon. This was an 8-year-old admitted for pneumonia. Cardiology referral for low heart rate during sleep. So now, first we'll see if it is sinus rhythm. Okay, so we know that P wave is followed by QRS, P wave is followed by QRS, P wave is followed by QRS with a constant PR interval. Yes, P wave is positive in 1, it is positive in 2, it is positive in ABF. Okay, so it is a sinus rhythm. Now we want to calculate the heart rate. So heart rate is 1500 by the number of small squares, which is almost 35 small squares, is 42 per minute. So definitely this patient is having a sinus bradycardia. So this patient will have to be investigated further to see if it is a physiological sinus bradycardia or if it is pathological. Okay, so this is a 6-month-old infant with fever and irritability. So again, now this patient is having a P wave followed by a QRS. P wave followed by QRS. It's difficult to see sometimes with this tachycardia. And normal P wave axis, which is positive in 1, 2, and AVF. So it is a sinus rhythm only. But the heart rate is 1500 by normal of divided by number of small squares. So 1500 by 8, which is 188 per minute. So definitely for a 6-month-old child, 180 per minute is tachycardia. But we know this patient has fever. So, you know, in when a patient has fever, for every 1 degree rise in centigrade temperature, you can have a 10 beats increase in heart rate. So this tachycardia will be normal, might be normal for the physiological state of the child. So it is a sinus tachycardia. So you have to know if it is physiological or if it is pathological by seeing the clinical scenario. So now we have a 3-year-old child, well growing, referred for a low heart rate. Echocardiography showed a left isomerism with an interrupted IVC. So what is left isomerism? So we know that in our body, the left side of our body and the right side of our body are different. So how I'm telling is, so the left lung has 2 lobes, right lung has 3 lobes. The left bronchus is different from the right bronchus. On the left side, we have the stomach and spleen. The right side, we have the liver. So this is how the normal body is. So left isomerism basically means you have a bilateral left-sidedness. So you'll have 2 left lungs. Both the lungs will have only 2 lobes. Both of the bronchi will be left bronchus. Okay. You have a left isomerism and you have a right isomerism, which is the opposite. So what happens here is, in a left isomerism, we know that you have a right atrium and left atrium. Now both of these atriums will behave like a left atrium, and we know that this sinoatrial node is a right atrial structure. So when you have both atriums as left atrium, there could be an absence of sinoatrial node. So the rhythm has to come from somewhere else. So we'll see where is the rhythm coming from. First, we want to know, is it a sinus rhythm or not? So now we know a P wave is followed by, each P wave is followed by a QRS complex with a fixed PR interval. Now we have to calculate the axis. Okay. Now the P wave is positive in 1, but it is negative in AVF and negative in lead 2. So definitely it is not a sinus rhythm. Okay. So these are the inferior leads, 2, 3, and AVF, and it's negative, which means the wave of depolarization of the atria is going away from the inferior leads, and AVL is actually positive, so it is going in this direction towards the left atrium. So this is otherwise known as a low right atrial ectopic rhythm, which is common in left isomerism. So even by the ECG, you can diagnose maybe this patient has a left isomerism. So this is an ectopic rhythm. Next, a 3-year-old during sleep. So this patient, if you now see his ECG, okay, you want to say is each P wave followed by a QRS complex. So we see QRS complexes, but we do not see any P wave before the QRS complex, but we see a P wave after each QRS complex. So definitely the first point of sinus rhythm is not there. Okay, so now here we know you have a normal narrow QRS complex. Each QRS complex is followed by a P wave. Okay, you can see the P wave in the round circle, red color circle. So this is basically a junctional rhythm. So what happens in a junctional rhythm is, instead of the sinus node giving the firing, the pacemaker will come from this AV node, and the AV node will now conduct its depolarization through the specialized conduction system and depolarize the ventricles. So whenever the ventricle is actually depolarized through the normal conduction system, it will be a narrow complex. But if the ventricle is not depolarized through the normal conduction system, but if it gets depolarized by muscle to muscle conduction or cell to cell conduction, then it takes a longer time. So in those conditions, the QRS will be wide. So if the QRS is narrow, we know that the ventricle is being depolarized by the normal conduction system. Okay, and we see a P wave after each QRS complex. That is because from the AV node, the depolarization is also like going down to the ventricle. It is going retrograded to the atrium and getting depolarized just after each QRS complex. So this is a junctional rhythm with a retrograde P wave ventricular atrial association. So there is some association. Again, a junctional rhythm, we can see a QRS complex and a P wave, negative P wave after each QRS complex. So we don't have a P wave before the QRS. So this is also a junctional rhythm because it is a narrow QRS complex. But the QRS escape is very slow. So this is a severe bradycardia. Must be only some 20-25 per minute. So this patient will need a pacemaker. So the previous junctional rhythm, you had a good rate, which could be a normal variant for a child during sleep. But a junctional rhythm with a slow escape has to be taken very seriously, and this could be needed. A pacemaker most probably will be needed. Now coming to this next rhythm. Previously you saw that the QRS complexes were narrow, but here you see that the QRS complexes are wide. So you have wide QRS complexes and there is no preceding P wave. So no preceding P wave and wide QRS complexes, we know it is an idioventricular rhythm, which we have discussed before. Okay, so but if you look closely, you can see P waves in the middle. So you see a slur over here. This is a P wave, this is a P wave on a T, and you have a P wave on T. So you're getting P waves in the middle with absolutely no association between the QRS and the P wave. So what happens is the impulse is coming from the ventricle, and because the ventricle is being depolarized not by the conduction system but by muscle to muscle conduction, the QRS complex is wide. Okay, and the sinus node is giving its beats by itself separately without any coordination with the ventricle. So you have P waves coming in the middle with ventricular atrial dissociation. That is called as ventricular atrial dissociation. No relationship between the QRS complex and the P wave. So this is an idioventricular rhythm. So this is coming to the rate and the rhythm. Now we're coming to the intervals. Okay, so intervals you have PR interval, QRS duration, and QT interval. So we'll go through each one by one. So PR interval is basically from the start of the P wave, okay, calculated from the start of the P wave to the QRS complex. It represents atrial depolarization and AV nodal conduction delay. So in adults or adolescents, more than 200 milliseconds or 0.2 seconds is abnormal. But in a newborn, we know the heart rate is faster, so all the intervals become shorter. So even 140 milliseconds, more than 140 milliseconds in a newborn or infant is abnormal. So you always have to know the age of the patient before you comment on any of the findings. So you can have a short PR interval and an accessory pathway or an ectopic atrial rhythm. Ectopic atrial rhythm we've seen before. So if you suppose it's coming from a low right atrial rhythm from the lower part of the atrium, that is very close to the AV node. So that's why the PR interval gets shortened. And why in an accessory pathway you have a short PR interval will come in the next few slides. So QRS duration is normally between 0.08 seconds to 0.11 seconds. It will be long in a bundle branch block or in a ventricular pacing or in a WP syndrome or in an indioventricular rhythm. So I told you, whenever the ventricle is depolarized by the normal conduction system, that is through the bundle branch to Purkinje system, it will be narrow. So in all these conditions that we have seen, bundle branch block, WPW syndrome, they are all depolarized only not through the conduction system, but through the muscle to muscle conduction. Okay, so more than 120 milliseconds in an adult is prolonged QRS duration, and for an infant it is more than 80 milliseconds. So QTC interval, okay, that is from the Q, that is start of the QRS complex to the end of the T wave. It represents ventricular depolarization and repolarization. So it is very important. You would have heard of the prolonged QTC syndrome or long QTC syndrome. So this differs by adult, by male or female, adult and child, and usually we have to use the Bassett's format to correct for heart rate. So we have slides regarding that later on. So I just want to, this boy, 4-year-old boy with recurrent episodes of tachycardia. Unfortunately, we couldn't get an ECG during the tachycardia, but when he came to us for examination, that time he was in sinus rhythm, but so we got an ECG at that time. So we can see the findings here. So you can see that this P interval is very close to this QRS complex. So it's a very short PR interval, okay? The QRS complex is wide, and you see an abnormal wave. You see this QRS going like this. This is the QRS complex. There's like a slur. There's a slur on this QRS complex called as a delta wave. So this is the Wolff-Parkinson-White syndrome. Okay, so quite common in children. It is a cause of recurrent tachycardias and sometimes even sudden cardiac death. So we know that the normal depolarization. So how do these findings all happen? So we know that the normal depolarization goes from the sinus node, okay, to the AV node, his bundle and bundle branches, then to the Purkinje system. This is a normal ventricular depolarization. And when this happens, the QRS complex will be narrow. But suppose you have sometimes in Wolff-Parkinson-White syndrome, you will have an accessory atrioventricular bypass tract. So I've told you that the only way the atria and ventricle are electrically connected are through the AV node in his bundle. But here you have an abnormal connecting tract called a bypass tract connecting the atria and the ventricle electrically. So now this sinus node can also conduct its beat through this abnormal atrioventricular bypass tract to the ventricle. Okay. So now because this pathway usually conducts faster than this normal AV nodal pathway, PR interval becomes short. Okay. So that is why PR interval is short. So why is QRS wide? I told you when the QRS gets depolarized to the normal pathway, then it will be narrow QRS complex. But here the QRS is getting depolarized to an abnormal pathway. So the ventricle gets depolarized by muscle to muscle or cell to cell conduction. So the QRS becomes wide. So next is the third finding. Why do you get that slur on the QRS complex? Because the QRS gets depolarized many times by this pathway and also by the normal AV nodal pathway. So because the ventricle gets depolarized by two pathways, there's a like a coalition and causes a delta wave. So this is the WPW syndrome and the explanation for all those findings. So coming to the conduction abnormalities, that is called as AV blocks. So we have 3 degrees of AV block. You have a first degree block. Okay. So first degree block is basically a prolonged PR interval. Then you have a second degree block. You have 2 types in that. One is a Mobitz type 1 and a Mobitz type 2. Mobitz type 1 is where the PR gradually lengthens and then the QRS is dropped. And as you have a Mobitz type 2 is where you have a fixed PR interval, but every alternate QRS or maybe every third QRS is dropped. I can have a 2:1 or a 3:1 block. Okay. Then a third degree block or a complete AV block where there is absolutely no relationship between the P wave and the QRS. So the AV node is completely like destroyed, and the P wave is beating separately, and the QRS is beating separately. So this is a third degree block. So we'll go each one by one. So this is a 5-year-old child with an ASD. Okay. So if you see, we want to calculate the PR interval. So the PR interval is basically from the start of the P wave to the QRS complex. If we zoom up the ECG, this is the P wave, start of the P wave to the QRS complex. So it comes approximately 320 milliseconds. So we know that in an adult itself, more than 200 milliseconds is abnormal. So this patient has a prolonged PR interval. Okay. So this is a first degree AV block. So we know that in an ASD, there's this is the right atrium, right ventricle, left atrium, left ventricle. You have a septal defect over here. So there's a shunting of blood from the left atrium to the right atrium. Now, because the right atrium and right ventricle receive more blood, it gets dilated. So this dilatation of this right atrium will actually cause the impulse from this SSA node to reach the AV node. It takes a longer time because the right atrium is dilated. So it's like a physiological PR interval. So many times this prolonged PR interval is actually physiological and does not need any treatment. Just observation. So this is another first degree AV block. Here the PR interval is clearly seen more than 200 milliseconds. Then coming to the Mobitz type 1, there's second degree AV block, Mobitz type 1 or Wenckebach. So here the condition is the PR interval gets successively prolonged. So this PR interval is 140 millisecond, next is 190 millisecond, then 200 millisecond, then the next P wave gets dropped, and so it continues. So this prolonging PR interval followed by a drop beat is called as a Wenckebach phenomenon. And many times in children, it can be physiologically present and does not need any treatment. Again, this is a prolonged PR interval and then a drop beat. So this is an elderly male coming with a calcific aortic stenosis. So now we'll track the P waves over here. Okay. So this is one P wave over here. Okay. This P wave is followed by a QRS complex. This P wave is not followed by a QRS complex. Then the next P wave comes, it is followed by a QRS complex. Next P wave is not followed by QRS. So every alternate P wave is followed by a QRS complex, and every alternate P wave is not followed by a QRS complex. So this is a 2:1 block. Second, which is called as a second degree block, Mobitz type 2. Okay. So this patient has to be investigated further to see if he has any high chance of going into a complete heart block. This is another child with recurrent episodes of syncope. So we'll now see his P waves and his QRS complex. Okay, so you have a P wave not followed by QRS complex, P wave not followed by QRS complex, P wave followed by a QRS complex. So if more than one P wave successively is not followed by a QRS complex, this is known as a high grade AV block. Okay, high grade AV block means that the block is below the His bundle. It's called as a infrahisian block, and this is a very, very malignant condition. It can lead into sudden cardiac death. So this patient will need a pacemaker. Now coming to a 1-day-old baby who is antenatally detected to have a slow heart rate. It is a baby antenatally detected to have slow heart rate. Mother had SLE. Okay, so if we see this patient's P wave and QRS complex, we see that P waves are coming over here, each P wave, and none of the P waves are followed by a QRS complex. Okay, so this is a complete heart block. So what are the conditions required to diagnose as a complete heart block? You should have a regular PP interval. Okay, you should have the PP interval which is faster than the RR interval. Okay, and you should have no association between the P and the QRS complex, which is called as an atrioventricular dissociation. So we know that mothers who are having SLE, their antibodies can go across the placenta during pregnancy and affect the fetal conduction tissue. So this is one of the commonest causes of fetal heart block. Okay, so mothers having SLE, each fetus has a 3% risk of having a heart block, and each subsequent fetus are almost 18 to 20% chance of having a heart block. Another example of complete heart block. So now we'll see, these are all the P waves. Okay, PP interval is 560 milliseconds, and these are the QRS complex. RR interval is 1680 milliseconds. So we know that the PP interval is faster than the RR interval, with absolutely no association between the P and the QRS complex. Okay, so this is also a complete heart block. Then calculation of the corrected QTC. So we know to calculate the QT, seeing the QT interval, you have to calculate from the beginning of the QRS complex to the end of the T wave. This is the QT interval. It represents ventricular depolarization and ventricular repolarization, its combination. So this QT interval highly depends on the heart rate. So it's bradycardia. When this bradycardia, the QT will be prolonged. When this tachycardia, the QT will shorten. So we calculate the corrected QT, which is known as the Bassett's formula. So the Bassett's formula is the calculation of the corrected QTC, which is QT by root of RR interval. Okay. So this QTC, normally we say generally the QTC is normally between 0.34 seconds to 0.44 seconds. But newborns, due to the immaturity of the heart, even sometimes they can have even up to 0.48 seconds. But it is important for these newborns to be followed up rigorously. So we have to make sure that the QT comes back to normal. Children and adult male, it should be less than 0.44 seconds. Adult female, it should be less than 0.46 seconds. So if it is more than this, you can have a prolonged QT syndrome. Gray zone is always between 0.45 to 0.48 seconds. This is the gray zone. So sometimes it's very difficult to find out the end of the T wave. So if you cannot find out the end of the T wave, for example, if the T wave does not touch the baseline, you have to calculate the QT by using the tangential method. So from the downward slope of the T wave, you draw a line till it meets the baseline, and that will be the end of the T wave, and the QT interval is collected. Calculated from that. So usually we use leads 2 and lead B5 to calculate the QT interval, but suppose it's not seen well in these leads, you can use any other lead where the T interval is where the end of the T wave is clearly seen. Okay, it's best to always calculate the QTC from multiple leads, and whichever has the longest QTC, that should be taken as the QTC. So it can be prolonged due to the genetic causes. You know, we used to say two types of prolonged QT. One is the Romanov-Ward syndrome, which is autosomal dominant without deafness, and you have the Jervell and Lenz-Nielsen syndrome, autosomal recessive with deafness. But now, generally, when we calculate when we diagnose a QTC, it has to be a genetic diagnosis. So there are almost 14 types of long QTC, each with a different gene. The commonest ones are long QT 1, 2, and 3. Okay, so now we have to give a genetic diagnosis. We no longer use the terms of Romanov-Ward and Jervell and Lenz-Nielsen. So abnormalities of QTC can be in electrolytes, problems, drugs. Certain drugs can cause prolonged QTC, and genetic problems, that is long QT syndrome. So different formulas are used, Bassett's, Friedreichia, Framingham, and all, but the commonest one which you use is the Bassett's formula, that is QTC by root of RR interval. So we'll come to some examples now. This is a 4-year-old boy with congenital deafness and recurrent syncope. So looks like the Jervell and Lenz-Nielsen syndrome. Okay, so now we zoom up to calculate the QTC. So now from the QT is calculated from the beginning of the QRS complex to the end of the T wave. So by the tangential method, we found that the QT was equal to 0.40 seconds. Okay, so almost 10 small squares. And the RR interval was almost 13 small squares, but so that's 0.52 seconds. But we have to do the root of the RR interval. So that becomes 0.72 seconds. Okay, so now we have to calculate the QTC, which is the QT by square root of RR interval, which comes to 0.40 by 0.72, which is 0.55 milliseconds. So more than 0.44 in a child is definitely prolonged, and the chances of sudden cardiac death and arrhythmias become more when it goes more than 0.50 milliseconds. So this boy definitely has a prolonged QT syndrome and needs treatment for that. Okay, so the rule of the thumb is, suppose like you have to see the ECG fast, or you don't have time to calculate the prolonged QTC if you're having a busy OPD. So generally the rule of the thumb is we see the QT and we see the RR interval. So if the QT interval is more than half of the RR interval, you have to diligently calculate the QTC syndrome. But if the QT interval is less than half of the RR interval, then most likely the patient does not have a long QTC. But it's always better to calculate the QTC by the Bassett's formula. This is another patient with a long QT syndrome. Here the QT syndrome was found to be more than 550 milliseconds. So the problem with these patients is they are at high risk for ventricular tachycardias, okay, and sudden cardiac death. So this was a 3-year-old child with history of recurrent seizures, okay, after playing, and it was because seizures, they were taken to a neurologist, okay, and the neurologist, everybody thought it was a seizure and gave medications, but it was not controlled by multiple anti-epileptic drugs. Okay, so this was one of my colleagues has given me this ECG. So it was then suspected that the seizures could actually be syncope. So this patient was put on a treadmill. When he was put on a treadmill, then we can see this bizarre arrhythmia came. So these are wide QRS complex. So definitely it is a ventricular tachycardia. Okay, and the characteristic axis of the QRS, it becomes high and then it becomes low. That is, becomes positive and then it becomes negative. So this is a twisting of the QRS axis along the baseline. So this is a typical just like this rhythm over here. So this is a typical arrhythmia known as the Torsades de pointes or polymorphic VT. So this is associated with long QT syndrome. And if a patient has recurrence of this or has an episode of a resuscitated sudden cardiac death, he will need a pacemaker. So that is why long QT syndrome is very ominous. So coming to the axes, okay. So now we have the axis. We can calculate the P wave axis, the QRS axis, and the T wave axis. So everything is very important. For calculating of all the axes, we have to always go back to our Einthoven's triangle and the hexaxial reference and know all the leads and the degrees. Okay. So now we'll come to the calculation of the QRS axis. You have two methods. One is the quadrant approach and one is the isoelectric method. So now we know that the based on this hexaxial reference, we can divide this into 4 quadrants. You have the left lower quadrant, left upper quadrant, okay, which is also known as the left axis deviation. This is the normal axis. Then this is the right axis deviation, which is the right lower quadrant, and this is the extreme axis deviation, or known as the no man's land, right upper quadrant. So now we just have to take 2 leads. So take lead 1 and lead AVF. So if both lead 1 and lead AVF are positive, it will be in the left lower quadrant, and that is the normal axis. Now, if the lead 1 is positive and lead AVF is negative, it will be in the left upper quadrant, and that is the left axis deviation. If the lead 1 is negative and lead AVF is positive, it will be a right axis deviation, that is right lower quadrant, and both are negative, it is the no man's land or the extreme axis deviation. So this is a quadrant approach. But if you want to know what is the exact axis, like the axis is 60 degrees, the axis is 75 degrees, then this method is not enough. What you can do is, another way of the quadrant method is, if you take 2 leads, either lead 1 or lead 3 or lead 1 and AVF, and you can plot the divisions. For example, you can take the area under the curve, which can be done by the computer, and plot it on each of the leads, or you can take the number of positive and negative divisions and calculate how many divisions for lead 1. So for example, this is 12 divisions for lead 1. For lead 3, it is almost 20 divisions. Plot 10 and plot 20, and then join the 2 lines, and then you can join it from the central axis, and you can get a degree. But this is like how much degrees specifically. But this is actually very, very tedious method. So nowadays, as you get more experience, you go to something which is known as the isoelectric method. So I told you one thing in the beginning. ECG is like a galvanometer. If the electromagnetic potential is going towards the positive lead, it gets a positive spike. If it is going to the negative lead, it gets a negative spike, that is below the baseline. Suppose it is going perpendicular to that lead, then you get an isoelectric line, isoelectric complex, which means the positive complex and the negative complex are equal. So we have to find that isoelectric complex. So suppose you take lead 1, lead 2, and lead 3. So out of this lead 1, lead 2, and lead 3, okay, we know that the lead 3, out of this AVR, AVL, and AVF, we know that this AVF is actually the most isoelectric when compared to the other leads. So if the AVF is the most isoelectric, we know that the axis has to be perpendicular to AVF, which means it has to be this, that is lead 1. Okay, so the axis can be on the positive side of lead 1, or it can be on the negative side, that is minus 180. So how do you know that? You have to see the other leads. So we know that lead 2 is positive. So if lead 2 is positive, it has to be 0 degrees. Okay, so this is the way you use isoelectric method. So we'll come to an example of an isoelectric method. So it may seem difficult at first, but with practice you'll get it. Okay, so the most isoelectric lead in this one is lead 1. Okay, so if lead 1 is isoelectric, the axis has to be perpendicular to lead 1. So now lead 1 is going from 0 to 180 degrees, so it has to be perpendicular. So lead AVF will be the axis. Now it can be plus 90 or minus 90. How do you know if it's plus 90 or minus 90? You look at the other leads. You know that AVF is positive and 2 is positive, 3 is positive. So if 3 is positive, 2 and AVF positive, it has to be plus 90 degrees. So you've calculated the how much degrees of axis it is. So by practice, you will get this method. So this is the isoelectric method of calculating the QRS axis. Now the QRS axis changes as you go from newborn to adults. We know that babies, newborns or fetus will have a right ventricle which is much thicker and more dominant than the left ventricle. In adults, the left ventricle is more thicker and dominant. So newborns will have mostly a right axis deviation. So even a 180 degrees or a 160 degrees axis is normal for a newborn. Then the changes of the left ventricular mass increasing happens mainly in the first month of life. Okay, so the left ventricle becomes more thicker slowly and the right ventricle decreases. And this process takes place over the 3 months to 3 years age group. So this is a transition period where the left ventricle starts becoming more thicker and the right ventricle becomes less thicker. So usually above 3 years of age and adults is where they have the left lower quadrant axis. So you see for a child above 3 years, 20 to 120 degrees is the normal axis, and adults minus 30 to plus 105 degrees is the normal axis. So usually the newborns will have a right axis. 3 months to 3 years of age will have a transition. It could be a right or left axis. And usually above 3 years or above 5 years of age, they will have the normal left lower quadrant axis. So it's important to know the age group to know if it is a normal or abnormal axis. QRS axis has very importance in congenital heart disease. For example, some conditions like AV canal defects, inlet VSDs, tricuspid atresia will have a left superior axis. Some conditions like tetralogy of Fallot, DTJ will have a right axis. So these will help us in the diagnosis of these congenital heart diseases. Now coming to some examples. So we want to calculate the axis. We're calculating by the quadrant method to make it easier. So we know that the lead one is negative. Okay. Lead AVS is positive. So if lead one is negative, lead AVF is positive, it will be in the right lower quadrant. So this is the right axis deviation. Okay. Coming to the next one. Lead one is negative. Okay, lead AVF is negative. So both lead 1 and lead AVF are negative. So definitely it is the no man's land. Okay, so extreme axis deviation, northwest axis. And we have another one. You have a lead 1 which is positive and a lead AVF is negative. So if lead 1 is positive, lead AVF is negative, it will be in the left upper quadrant, which is left axis deviation. Okay, so this is the quadrant method of calculating the this one. The axis. Suppose you want to use the isoelectric method, then you see which is the most isoelectric. In this one, definitely lead 2 is the most isoelectric method. So lead 2 is 60 degrees. So it has to be perpendicular either to lead 2. So it can be either 150 degrees or it can be minus 30 degrees. So you have to look at the other leads. So if AVF is negative, then definitely it has to be towards minus 30 degrees. So it is a left superior axis degree. So now I know it is a left upper quadrant. I also know that the axis is around minus 30 degrees. Okay, so this is the isoelectric method, left axis deviation. Then coming to something called the QRS rotation or the transition. So now this axis was calculated actually in the frontal plane. Now the QRS rotation or transition is calculated in the horizontal plane by seeing the leads of V1 to V6. So in adults, the left ventricle is more dominant. So we know that the leads V1, which is over the right ventricle, will show more of a small R wave and a deep S wave. And when we come to V6, it will be more of the R wave because the left ventricle is dominant. Okay. So V3 and V4 will show the transition between these two. So now the normal QRS transition will be around V3 to V4 leads. So sometimes the transition, if it is towards the right of the V3 lead, like this V2 or V1, it is called as a counterclockwise rotation. So you're looking from the foot, patient is lying down, you're looking from the foot of the patient. So if the transition goes to the right, it becomes a counterclockwise rotation. And if the transition goes to the left of V4, it is a clockwise rotation. So this has some importance. For example, if you have an early transition or a counterclockwise rotation, it could be a right ventricular hypertrophy, a posterior MI, or a newborn ECG. If it is a clockwise rotation where the transition is delayed, okay, it could be a shift of the heart. So patients who are having dextrocardia, because the heart is on the right side, the left leads do not get any complex. So they will have only S waves, even up to sometimes V5 and V6. So shift of the heart, emphysema, and a vertical heart will have a delayed transition. Okay. Next is abnormalities in P wave. So we have went to QRS axis. Now we're coming to the P wave axis. I think maybe we can take P wave axis in the next class. Is that okay, Dr. Karthik? Almost 1 hour.
Yes, sir. That's fine.
Because I told like it's we have to go very slowly. And
yeah.
So I don't want to rush. It's better like
that's fine, sir. We can have another class also.
Yeah, and then maybe we can complete in the next class. So is there any doubts actually up to now? I know it's a lot of information, but you have to go back and read. You cannot just master ECG by just listening to one lecture.
Yes. So far, there is no doubts in the live chat section, sir. We have few pupils in the Zoom with us.
Okay.
If they having any doubt, also we can go with them.
Okay. I have to open the
stop?
chat.
Shall we stop the session from here, sir?
Yeah, we can stop the session.
Okay, sir. We'll wait for 2 minutes. If we are having any doubts in the live chat or with the people who are with us in the Zoom,
okay,
we can clarify. Otherwise, we can wind up the session, sir.
Okay. How many are participating actually?
People were coming and going, sir. I'm not sure. At one time, there were 10 people who are watching it live.
No problem. Okay.
They will be coming and going out.
No
So
problem.
after the live chat section, we can see how many views are total.
No problem. Okay. Fine. So I'd like to thank everybody for a patient listening.
Yeah,
We'll
as
continue in the next
per
class.
the title, sir, it is a complete package of ECG. It is A to Z. You made it very detailed and very clear.
Hope everybody is able to understand. But you can always go back and look at the linked videos and read the textbook. So mastering ECG, even still, I have not mastered ECG, but it's still mastering. But it takes a long time. So we have to go on reading and updating our information.
Yes, yes. Any lecture after that, if you read the book only, we people will understand better.
That's correct. That's correct.
That should be a habit after the lecture.
Exactly. Exactly.
You can stop your screen sharing, sir, right
Okay.
now.
I'll do that. Fine.
So we don't have any doubts so far in the live chat section,
No
sir.
problem. No.
We can wind up, I think.
So I am very happy. Maybe everybody understood.
Definitely, sir. People would have definitely understood. It was really a good topic, and it's a great privilege for us. Thank you so much, sir.
Thank you very much. We'll discuss with Dr. Balaji when we'll have the next continuation.
Sure, sure, sir. We can
Okay.
have it probably in the next week. We'll discuss with Balaji, sir.
No problem. No problem. Okay.
Thank you,
Thank
sir.
you very much.
Thank you so much, sir.
Bye bye. Thank you. Thank you.
Thank you, sir. Okay, viewers, we have I have few announcements for you today. Tomorrow also we are having some good sessions. 21st May 2020 Thursday. We have 3 sessions: 3 to 4 p.m., 5 to 6 p.m., and 6:30 to 7:30 p.m. The first session will be on free radicals and antioxidants. This will be delivered by Dr. Vasant Gosai. And second session is blood transfusion, and this is going to be delivered by Dr. P.S. Sharma from KIMS Amalapuram. And third session is examination of pupil. This topic will be delivered by Dr. Rachita Daniel from SRM Medical College. So thank you so much. Please join us tomorrow for these wonderful topics. And thank you very much. I hope you all enjoyed the session. This was really a nice presentation from sir. Please spread the word to all of your friends so that everyone will get benefited from this. And share our YouTube channel, share our Facebook page. In FB page, we have all the important announcements and these recorded videos, MCQs, everything we are posting in the FB page. So please do follow in the FB, and please do subscribe and share our YouTube channel with your friends. Thank you all. Thank you so much. Thank you for joining.